Okay, let me stop showing these banners. It is Saturday.
Yeah.
Ooh, when I tell you, I I don't know it felt like a long week. it felt like it felt like a long week, but it just sped by. I think that was the for me. Like
Okay.
like I turned around and I'm like, oh my God, it's Friday. Oh my God, I got this. Oh my God, I got that. It's been a lot. It's been a lot. But God is still blessing and I can't complain.
Right.
No need to complain. Just, do what you can do, when you can do it, how you can do it. That's all I got.
Right.
That's all I got. How was your week?
It was okay.
Okay.
I agree. It was kind of like a long, fast week.
Yes. If that makes sense at all. But yes.
Hmm.
Yeah. And then, yeah, all the things, all the things. Okay, well, I guess we can get started. No feedback, you good? Everything's good in the
Oh,
world?
great.
Okay, okay. Well, hopefully on the back end, because I heard that I said, oh, that didn't sound right at all. So I'm glad we had an opportunity to kind of look at that and check that in. Good morning, Renita. Welcome, welcome. All right, let's see, let's see. Well, welcome everybody to our Saturday morning tea, where we discuss health information, news, education, certification tips, the weather, entrepreneurship, how long the week, how long and quick and slow the week has been, and the revenue cycle at large. And don't forget, as you come in, hit the thumbs up or the like button. We appreciate that engagement. I am Clarice Warner, the girl with the pearls, the founder and senior education director of the Professional Reimbursement Network, LLC, where coding education is key. PRN is a healthcare compliance consultancy located in Cincinnati, Ohio, that specializes in revenue cycle and regulatory compliance and education. So, in that vein, let me ask you, do you know what it takes to be a certified marketable medical coder? Do you? Do you really? I mean, really, 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 really? Well, before I introduce my co host, let me share with you information on a free, yes, free 99 email course on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start and scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. See, I'm gonna do your next ad. So when you tell me in advance that you got, a class coming on, look, I got something for you. I'm gonna figure it out. Oh gosh. Okay. If you are in Clubhouse, feel free to click the link if you are interested in getting more information about the 5 steps to become a certified marketable medical coder. Let me just welcome those. In the last couple of weeks, we've had several folks get information. So if you have any questions, feel free to reach out to me. If you are in YouTube or joining us via YouTube, Facebook, and or LinkedIn, check out the video description for the link. I promise you it's down there. Just scroll, you'll see it. Joining me today is my illustrious co-host, Mr. Jesse, the registered trademark. Put some respect on his name, the coding nurse. Just famous. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia. I have been an LPN for 30 years and switched to HRM in 2014 during the pandemic. In 2020, I created a company, the Coding Nurse LLC, where I help nurses and other practitioners with um, bedside experience and hands-on clinical experience transition into the wonderful world of HIM.
And isn't it wonderful? Isn't
It
it
is.
wonderful? It is wonderful, wonderful. Believe it or not.
All the ups and downs.
All the ups and downs, all of it. So before we jump in, let me remind you that if you are on Clubhouse and want to join into the conversation, all you have to do is raise your hand. We're here. And if you are joining us via Facebook, YouTube, and LinkedIn, you know what to do. You can use the chat. Remember, this is a conversation and your opinion matters here. So don't be shy. Let us know. We want dialogue. We're here together to hear your opinions and thoughts on some of the things that we bring to the table, to the tea table. So feel free to spill some tea of your own. If you have any questions, and you are using the chat function, please type a Q first so that we know it's an actual question and we don't miss it. So let's get into it. Let's get into it. But first, we have church announcements. Wait a minute. You're gonna be laughing at me. Wait a minute, hold up. I hope this works. We'll see. You know I'm always playing, right? You know I'm always playing. So we got some church announcements for the day. A little attention, okay. Oh wait, do I turn it up? Let me try this one. Yeah, that'll be. Yes, okay. So really, my only church announcement today is I want to take this time to congratulate all of the graduating health information students that are graduating this spring/summer. You've done all the work, put in all the effort, and I just want to congratulate you on your success. One of my favorites, and I know I read somewhere that there's all kinds of controversy around this, but it's still one of my favorites, Dr. Seuss. And I just want to share with you all the places you'll go with HIM. So let me encourage you to find and follow your passion and enjoy the ride. Mr. Jesse, you have any church announcements, or anybody have any church announcements? Okay. All right. Wasn't that fun? Yeah. I said, when you said that, I said, oh, let me find some music. Let me pull it all together. And here we are, church announcements. Let's see. Hey, everybody. Good morning. Good morning to the crafty coder. I'm sorry, Renita, I didn't put yours up here. Good morning. Y'all laughing at me at my church announcements and the music. I know I have a problem. I love to play. Okay. So let's get into it today. So today we are talking, and so for those who are just joining us, today we are discussing telehealth fraud and some new OIG enforcements. It was a light coding week, at least in my camp. I didn't see a whole lot of information out here specific to medical coding, but we talk all things. And so I just wanted to bring some things to your attention. So you all know we have ended the
Before you start,
go ahead, I'm sorry.
I just wanted to interject that because I sent you something last night on Instagram, but you probably haven't seen it yet.
I have not.
We've been talking for weeks and weeks and weeks about full practice authority and how.
Somebody got something?
How about in Tennessee? And apparently there's a few other states. The AMA is trying their darndest.
Oh, excited.
They are, forever, foreign medical graduates had to come here and they had to take an American residency program.
Wait a minute. You put the church finger up, sir. Okay, I'm sorry.
I was raised right.
Hey, yes, sir. Yes, you were.
So Tennessee and a few other states are now allowing foreign medical graduates to practice in the United States without going through a United States residency program first.
Wow. That is huge. So that is huge.
So look, you can go buy a medical license somewhere and come here.
And go to Tennessee
Mhm.
and get all the love and glory.
And it seems there's a few other states I had to do some research to find out, because there is under the guise of addressing
The shortage.
the shortage in rural areas and in unserviced areas.
So you gonna kill? I'm sorry. Did I say that out loud?
Yeah.
I'm sorry. It came straight out. I'm sorry. So you're gonna put. So you're placing the possibility of putting those in rural and underserved areas in harm. I guess that's the more political way to say that, isn't it? Wow. But not give those who have been trained in medical or in a different vein of medical training the opportunity to practice medicine on this population.
Mhm.
Just let whoever come over and wow. Wow. Ma'am, exactly. She said the side eye. Yeah.
Mhm.
I wow. That's huge. We're gonna have to do some see I feel some more digging. We're gonna have to do some digging on that. That is huge.
It is. I just wanted to just put it out there. I was like, wow. That's their
Interesting.
answer.
So that's their answer. Bring more medical doctors over. And I mean, I guess I can appreciate the medical doctors, but not without so how are they did they provide any information on how they're vetting them, or it's just come on over, we gonna set you up?
If they don't have to go through a U.S. based residency program, I don't see how you could then.
And is this already effective or it's becoming effective?
Well, in Tennessee, they just passed the law, so I don't know when it's going to become effective, but there are. So it's going to happen definitely sometime fairly soon. And there's because this said Tennessee joins a few other states, so I got to do some digging to find
Oh, so it's
when.
other ones already out here. Oh my goodness.
Mhm.
That's scary. Check on y'all rural folks, people.
Yeah,
Check on them.
yeah, exactly. Yeah,
This is I have so many questions. I have so many questions.
yeah.
So what does this look like from a payer perspective? Like when they because they do all those when you credential with payers and wow, this is huge.
Mhm.
Hmm. She said she said the crafty coder says between that and the nurses doing only long-term care, it's a setup, population control. I know before I it just came right on out. Wow. Yeah, check on your rural family members. Check on your rural family members.
Look,
Um,
when I read Crafty Coda's comment about long term care, I had a case this week that was horrible, and it's like that's another thing nobody has ever addressed. Long term care has been understaffed for at least 25 years,
mm,
and I have an ongoing case now. It's horrible. The the person had a stroke and had brain damage, so they have a trach, a peg tube, and they're nonverbal, but they're
mm,
alert, but they're nonverbal,
mm.
and um, was receiving a tube feeding and was laying flat and aspirating. And when I was working in long term care, it used to drive me crazy when the nursing assistants would lay somebody flat when they have a tube feeder, whether it's active or not, you never lay anybody with that condition flat ever, 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 unless you're changing them. But the bed should never go below 30 degrees.
Mm,
It's that's a setup that it always happens.
mm, mm,
He's starting to turn around, thank God. I mean, he was impacted. It was just a mess.
mm.
Head sores, but thankfully he's turning the corner. Well, they're turning the corner.
Thankfully, thankfully, look, that's a mess. Yeah, and yeah, we're gonna talk about that too, because I know there's all kinds of um enforcement or reviews of some of the rules surrounding long-term care. There's shortage. Yeah, we talked a little bit about the medication that they were using kind of to help with the shortage in staff to control the residents so that they could, which is crazy, but that's a check on everybody. Look, everybody just check on everybody at this point. It's a lot.
I really think the answer is they need to, whatever money they give said facility for Grandma Rose, they need to pay the family and just let her stay home.
Pay the family.
Exactly.
Because
So they have programs where you can get paid as a caregiver, but it pales in comparison to the thousands of dollars per month that these nursing homes and these facilities get. Pay them what you pay these people, and you'll see a much better outcome.
much better outcome. You're absolutely right. Wow. That's that's a sad day now. Hmm.
Well, I mean,
No, you're fine. Okay, so real quick, because I got a tight hour. Um, Telehealth. So we have ended the pandemic, and so a lot of things are going back to their relaxing the flexibilities that they had, or I'm sorry, going back to what they had before they relaxed the flexibilities for a lot of services, and telehealth was one of them. And folks have been gathering data on folks. When I say folks, the government has been gathering data on all kinds of things that have happened during COVID with telehealth services. And if you know anything about the government, once they start collecting data, you can best believe that reviewing, auditing, all of those things are closely behind. And so they have come up with some information. Wait, I got it somewhere. Some information regarding some of their findings. Let's see. I had it. Some of their findings related to, okay, I got it. Some of their findings related to telehealth services. And I wanted to share with you what some of the things that they found. So let me share my screen. I know. They always tell me you need to have a separate monitor, but we don't. Okay. So so this comes from the OIG, and gives you a little background on some of the things that they have been seeing. And so these are 7 measures that may indicate fraud, waste, or abuse in telehealth services. So they're kind of putting you up on game. They're trying to let you know, hey, these are some of the things that we've seen. These are some of the things that will uh, uh, make us raise our eyebrows and may cause us to contact your organizations. And some of these things, when I read them, I was like, well, why would you do that? But I don't know, folks. Folks be folking out here. So the first one, billing both a telehealth service and a facility fee for most visits. when they see billing telehealth services at the highest, most expensive level every time, billing telehealth services for a high number of days in a year, billing both Medicare fee-for-service and a Medicare Advantage plan for the same service for a high proportion of services, billing a high average number of hours of telehealth services per visit, billing telehealth services for a high number of beneficiaries. And I think that will be the one that may catch folks the most. And then billing for a telehealth service and ordering medical equipment for a high proportion of beneficiaries. And so they put this out here as kind of FYI. And then there's more information that talked about when they were during the pandemic, the different things that they were seeing. They published a report a while back about the risks of telehealth with Medicare services. And they said from March 2020 through February 2021, they had 1,714 providers who billed the program for a telehealth service. And they had concerning billing on at least one of 7 measures. And so they developed this kind of infographic to let folks know. So if you have billed telehealth services during the pandemic, somebody check y'all records. Make sure y'all stuff is right, please. And thank you. Mr. Jesse, you have anything on that?
It's hunting season, that's all I can say.
It's hunting season. You are absolutely correct. She said, oh, this is about to be good. Yes. Because they done, all they can say, we done told y'all. We done told y'all. Period.
What I'm curious about, and they're not saying anything about it, and I'm sure they'll get around to it. But I want to know, when is the OIG going to launch their criteria? Because during the pandemic, all these people had these clear labs. And I want to know, when are they going to start auditing those? Because it always said, now they made it very clear from the beginning that you could be subject to a post-payment review. I just want to know, when is it going to start?
I wonder, will they do that through OIG? Will they do that through HRSA? Who's gonna lead that task?
You know what? It probably would be HRSA, because they were the ones that were.
Yep. That will be interesting. I need to look into that, because there may be some things out there for me to see from a HRSA perspective.
I can tell you it's hard going. I know that for a
fact. Out here in these streets, the fraud. I love it. Let's see. She said they don't believe there is really a post-payment review board at these payers. Yes. A whole board, a whole bunch of folks getting together, deciding and discussing, hey, these are the risk areas. It's all about a risk assessment. These are the risk areas. These are the things we saw. And then let's put together the plan to begin that work. And again, that's some of the things that organizations and or providers as a whole should have in their back pocket is exactly, things to see and do. Exactly. Look, you felt me. You felt that in your whole spirit. Yeah. So that's like one of the things that you can do is just to make sure and check. And it's nothing wrong with making sure your stuff is right. Make sure your house is in order. Above all, because it's one thing, and I think folks are quote unquote fearful of what they may find, but it's better to be proactive than to be reactive. It's always my motto. And proactively if you find something, you can say, hey, we didn't know, we made a mistake, we are learning, we checked, blah, 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 slide the check, here you go, thank you, walk away. Versus, well, hopefully they won't find me, maybe they won't. And then they come knocking, and then it's a whole different type of animal, it's a whole different type of conversation. And it's better to be on that front end conversation versus that back end conversation. That's my tea for the day. So yeah. So speaking of other enforcement, these were the things that I ran across this week. So we had another one of these Medicare Advantage compliance uh, things going on. Okay, another one of these Medicare Advantage compliance things going on, and they not playing with everybody. So this one was an audit of specific diagnosis codes that Keystone Health Plan East submitted to CMS. This was dropped on the 30th. Are they?
Yes, they are.
Well, look how I did not know that. Look at God, just bringing stuff together. I did not know that. So pretty much actually they got some grace. Believe it or not, they got a lot of grace because so they did a sample. They looked at some diagnosis. This is all about risk adjustments and how they calculate the information for their enrollees, and looking at the health status of those enrollees determines the payments that they get. And there are some diagnosis codes that, of course, are at a higher risk for being miscoded because, one, they get a higher dollar amount for those. And if they're miscoded, of course, that equals an overpayment for CMS. So what had happened was the OIG sampled 270 unique enrollee condition and payment years with these high-risk diagnosis codes, and I'll tell you those in a minute, for 2016 and 2017. And so what they asked them to repay was, well, their review was totaled to $746,012. Well, what they found was 205 of the 270 sampled enrollee years that the medical records that Keystone provided did not support the diagnosis codes and resulted in $550,000 and some change in overpayments. And they were going to extrapolate. This is where the grace came in. They were going to extrapolate, and because they felt like they estimated that Keystone received at least $11.3 million in overpayments for 2016 and 2017. And I think they was about to pull that trigger. However, Keystone had some comments, and they stated it was something they stated there. So they recanted, or they went back to their work and they changed it. Because initially I think they had 207 errors and they changed it to 205. But then when the draft report went out, they learned that CMS had updated their regulations for audits in their risk adjustment program, and it specified that extrapolated overpayments could only be recouped beginning with payment year 2018. So they got some grace. Because their audit period was for 2016 and 2017. So they only asked them to refund the overpayment that from the sampled enrollee years and did not extrapolate. So they got a whole lot of grace, especially since they had estimated that $11.3 million figure. So that was wow. That was wow. The high risk codes or diagnoses that they looked at were some that we have seen before and talked about. Acute stroke, acute heart attack, embolism, vascular claudication, lung cancer, breast cancer, colon cancer, prostate cancer, and major depressive disorder were the ones. Oh, here it is. If I'd have kept reading, it said based in Philadelphia, Pennsylvania. Yeah. So, and then they looked at so the 270 sample came from looking at 30 records from all 9 of those high risk diagnoses codes.
Did you see her comment?
Wait a minute. Wait a minute, hold up.
She done done the bad calculation.
Oh my God. My cut for conducting the audit, right?
Did you hear the sample size? 207 cases. That's nothing. Now, how they picked 207 cases, they use, what is it, rat stats? Something like that. So they pick a sample from,
and everybody is privy to rat stat. Anybody could get rat stat. You just download it.
Right. So I'm like, that's why I'm telling you, like, the opportunity for entrepreneurship in this space is huge because 207 cases. I mean, when I was working, I was doing 75 a week, and I was just BSing. So seriously, so if you have like just 2 or 3 of y'all, you could knock this out in 2 weeks. And then everybody just review everybody else's, and there you go. Because like honestly, but I'll make it fast. I know we got
No, go ahead, take it out.
But so what's going on is now all this has to do because I noticed that now, like even at my job, I'm inpatient CDI. They have been talking a lot about HCCs, and they're getting ready to do some education for the CDI people. So I figured out why, because we know now that version 24, which I think is going to come out next year, it's all about documentation because the weights have already changed. Like the risk adjustment factor scores have already been adjusted. So they're kind of almost even now.
Okay.
So now you only get credit for documentation because what's going on in all these situations is you have people who are basically upcoding. That's really all it is.
That's what they're doing.
And without any documentation. So now they're focusing on documentation. And what I've noticed in all my years of risk adjustment, most of your heavy HCCs will come from inpatient stays. But a lot of HCCs are found in incidental findings that aren't addressed in the hospital setting. So you cannot code from that because a lot of times it's on radiology, an echocardiogram, something because they always find, aortic dilatation on an echo, pulmonary hypertension on an echo. But if they don't treat it, then you can't
count it. Yep.
So there's always been a lot of missed opportunities. So now the push is, I think the push is going to be to try to get inpatient to pick up all of those rock solid, HCCs to kind of bolster so we can, look, what this person was in the hospital and this condition was documented during this year. You only have to document it once. So I don't know how that's going to fly because you still have to have meat. It's okay to have the address, but what did you do for? You still have to have treatment. You still have to have some kind of oversight for this condition to get credit for. So I'm just interested to see how this is.
Right, and you also need to consider the medically necessary reasons for that, because if you're in for something else, then all your resources are going that. And I know oftentimes, oh, by the way, but that's not necessarily how it works. By the way, you can't just be like, oh, well, we got you here. Let's just open you up, do all the things. No, unless they're related, or yeah, that's gonna be real interesting because now they gonna creatively put together some of these practices, which yeah, here we go. They'll be auditing MCC or HCCs next.
And when it comes to cancer, even inpatient providers get it wrong. Like, how hard is it to put a
A
history of?
history of. It's not
That's
there
all.
anymore. It's not.
Exactly.
It's not. It's gone. And then the crazy part is you'll see all the documentation that says they're, in remission, or there's nothing going on with whatever, or it's been 30 years or whatever. It's like, really? Come on, y'all. So arrhythmia turned into strokes and heart attacks magically. It's like Lucky Charms over there in these streets. Go ask them what MEAT stands for and see what your answer is. Oh yeah, this education on documentation is gonna be it's gonna be a doozy. It's gonna be a doozy.
'Cause I had my last case yesterday. The person had a history of lung cancer, but they put down that they had small cell lung cancer and malignant pleural effusion. Okay, you have to have an active cancer to have malignant pleural effusion. So I just coded it as pleural effusion because
Now you know they're gonna come back and knock on your door, sir. And I know you're gonna be right there ready for them.
I just got, because I mean everything gets audited. I just got a audit from, actually, the coder reached out to me. They reached out to the coder, not to me. I don't know why, but I ended up sending it to my manager because it was a case that I oversaw. The person came in for bariatric surgery,
Mhm,
and they also had a hernia repair, but they said that they repaired the diaphragmatic defect.
mhm,
So, that's, so a diaphragmatic defect can be a hernia, but it also can be congenital.
mhm,
So so I saw the op note the day after the surgery was performed. I sent the provider a query,
mhm,
and he responded back that it was a congenital diaphragmatic defect, which will boost up your DRG.
mhm,
So also, the person came in for surgery, and all of their vital signs were normal, all their labs were normal. The WBC was 7. After surgery, they had an infectious disease consult, and the infectious disease doctor documented post-op fever, new onset of leukocytosis. So the person went on to be diagnosed with sepsis. The EIQ request, because that stands for something, the request was the query for the etiology of the diaphragmatic defect and the query for sepsis,
mhm.
ruled in or ruled out. First of all, so I sent it to my manager. I'm like, well, I did send a query for the congenital defect, and the person did not meet any clinical. It did not meet any clinical criteria for sepsis on admission. It's clearly documented post-op fever, new onset of leukocytosis. So I did code the sepsis, but I coded it as not present on admission. Because in this hospital, they seem to think that sepsis trumps all. It does if it's present on admission, not if you get it afterwards. So towards the end of the day, she responded back and said that she reviewed the case and she would let them know, but she agreed with me.
And you just explaining that and speaking on that particular case, that's probably why. Because I always ask, why do we see all of these sepsis cases? That's it. That's it right there.
Mhm.
That's it. They see the word sepsis and they get gung ho and just listed as the principal and think, okay,
Mhm.
we here we are. That's it right there.
Yeah, but you got to review. I always go to like those initial labs, those ER labs, and I mean, if they had the criteria, then hey, okay, all right. But post-op fever and new onset of leukocytosis, that's a no-brainer.
That's a no brainer. I don't understand. So, and we say all of this to say, especially to those who are interested in our field, you see how technical it is? You see, I mean, it's not just, oh, I get a diagnosis, let me go get my book, or let me go to my encoder and generate a code. There's information behind it, so you got to make sure there's information behind it to support that code. You can't just be slapping codes on stuff thinking, oh, okay, I've coded. Did you really? Did you really?
Oh, I got
The spirit then just hitting right there. Did y'all feel that? I think it was the organ on them church announcements, but go ahead.
You want me to praise break too? I had a surgical case. The person came in for right hip fracture. Everybody X-ray confirmed right hip fracture. The ED, the body who did the H&P, they go to surgery. I read the op note. Why did the surgeon say the left hip was replaced?
Excuse me? Wow.
And I sent the surgeon a query 2 days ago, lining her back. Normally they are right on it.
Wow.
But here's the kick. The coder already coded the case as a right hip replacement. Based on what documentation, man? Where does it say the right hip was replaced?
Mm, mm, mm. Mm, mm, mm. Wow. That's a mess. A whole mess.
Mm-hmm.
She said, and following the freaking guidelines, and you won't have too many issues. Well, as we always talk about, they don't know what's a guideline.
Mm-hmm.
If it ain't in the coding clinic, it don't matter. What's a guideline? Bless their whole hearts. Uh, right. She said she probably coded surgery from the header only on that op report.
But Cracky Coder, even the post-op diagnosis said left hip
They ain't read that. They just saw the first one. They ain't pay attention to any of that. Renita says, now, I want to probably says, no way. This field is deep and intended if you want to do it the right way. Reading is fundamental. Oh my God, I say it all the time. Yes, it is. Yes, it is. Mm-mm-mm. Crazy. Well, we did have some coding things, didn't we? Just from that OIG enforcement. Um, let's see. The other one was a little more egregious. So there was a physician who got popped, sentenced for stealing approximately $250,000 from COVID-19 relief programs. Imagine that. Imagine it. Colorado physician was sentenced to 2.5 years in prison for fraudulently obtaining and misappropriating approximately $250,000 from two separate COVID relief payments. Dude was the supervisory physician at Springs Medical Associates, which is a medical clinic with 3 offices in Colorado. He applied for, and Dr. Francis F. Joseph applied for and received government funds from COVID-19 relief, from the Accelerated and Advanced Payment Program, and the Paycheck Protection Program. So he got all the little dollars, and should not have. And as a result of those items, we told y'all they was coming. They was coming. He now faces 2.5 years in prison, or will face 2.5 years in prison. It didn't say anything about his license or any of that. I don't know, but yeah. So that came from the criminal division, from the OIG. Yeah. And then the last one I wanted to share with y'all comes from Indianapolis. and a woman facing federal charges for stealing a nursing license in order to fraudulently work as a nurse in Indianapolis nursing homes. Y'all, they taking us out, ain't they? So, Miss Rochelle Perry of Indianapolis, Indiana, with 5 counts of Social Security number fraud, 3 counts of aggravated identity theft, and 1 count of Social Security disability benefits fraud. Um, Says she stole a Social Security number on uh she submitted 5 fraudulent applications for employment to, I guess she heard that there was a nursing shortage. Let me stop. But anyway, she submitted 5 fraudulent applications for employment to Indianapolis area nursing homes and assisted living facilities. And she used stolen Social Security numbers on all of those applications. She received Social Security disability insurance benefits under her true Social Security number, and she knew that those benefits would be reduced or eliminated if the Social Security Administration found out that she had a job. So she getting all of the dollars, right? Perry knew that she might not be able to pass an employment background check if she applied to a healthcare facility using her true Social Security number. So in some of these applications, she used a stolen LPN license number to trick the employers into believing she was an LPN. She has never received any type of nursing license in the state of Indiana. But the thing is, she got a job. Can we talk about that part? She actually got hired. um, she worked as an LPN at one facility for some months, January 21st to April 27th. At the second facility from May 10th through November 23rd, and the third facility February 26th through April 16th. Hey, my birthday, April 16th. And so during all of that time, she received approximately $55,000 in Social Security benefits under her true Social Security number. But then she also received, of course, her salary from working as an LPN. So she was getting all the numbers. Now, my question is, do you also go after these facilities? Because clearly, if you're receiving federal funds, which most skilled nursing facilities would, Medicare and possibly Medicaid, because usually Medicaid pays for skilled nursing care. I don't know about the assisted living piece. That's something different. You're not supposed to have anybody. You're supposed to check. You're supposed to do that's part of the compliance due diligence of the people that you hire. You're supposed to validate these licenses. You're supposed to make sure that all is well with the world.
But no, I think that they did that because like since I've been a nurse for 30 years, I've been knowing this has been going on for about 28 of them. What happens is if you take, like, she probably had a name that was similar and she used her social security number. So, because that's what's linked to your nursing license too, your social security number. So, if she was able to get the number and then get the name, they might not even have a. They don't check the picture when you are going to get.
Do they post a picture? Is there a picture available? Do they make them give a picture?
The only picture you have is when you make your initial application to the state for the examination.
Well, maybe that's the problem right there. Like when we go to the doctor, they want to see an ID, they scan that ID. Maybe they need to have some kind of pictures of folks so you can say y'all don't even look the same. For real.
But once you start working, all they do is they go online, they punch in your numbers, they might have to punch in the last 4 of your socials. I've seen it done. And once that report comes back and it's active, okay, well, you're good to go.
So she did this in 2020, and if she got let go or they discovered she wasn't, well, clearly, if you prayerfully, she hasn't harmed any people in this mess. I didn't see anything where it mentioned that type of um I didn't see anything where it mentioned anything related to that. This was primarily because she was double dipping and getting the Social Security money and a salary. But I mean, I know there's a shortage. I know y'all need people. I know, but you can't not do the checks, because if there was a month gap in between almost all three of these instances, and nobody reports, like, hey, I don't know. I'm
Because she could have just, because what she was doing was she was probably, not working at places too long, so she could escape it. But I'm gonna tell you how she got caught. Somebody reported her. That's how. Because what happens, how
she
people hate.
she
She was getting that good government, Social Security money, and she was working.
Mm.
Somebody told, because she was around there flexing, especially during the pandemic. Oh yeah.
Where you get that from, ma'am?
Exactly. Well, I thought you were disabled.
Mm,
And then they probably saw her in scrubs. I'm telling you, somebody told on her.
Be like, what you know about nursing?
Exactly.
What you know about healthcare? What you know about scrubs? Are you scrubbing scalps? Ah, I cannot. Look, she was like, she probably got a PPP too. Ah, oh my God. Well, these folks, and I guess so. I'm sure my mouth's gonna be dropping for as all of this stuff continues to be revealed, as the creativity of folks in doing what they got to do. Because really, look, she heard the news. It's a nursing shortage, and so let me go on out here and help these poor folks that need a nurse in their facilities. And I don't watched enough ER or Grey's Anatomy or whatever to figure out, oh, just do that, second, and third. Or maybe she even went on YouTube University. I don't know.
She answered the clarion call. Okay.
She was helping the world.
Yeah. In their time of need.
In their time of need. Please check on your seniors at these assisted facilities and side eye anything that looks crazy. Please, y'all.
Better.
We got physicians coming in without any regulatory or medical review checks from the government, and now we got nurses. Well, we've been had nurses, but just check on your folks. That's all I got. Check on your folks. Bottom line, check on your folks. Wow, that was funny. She was getting all the coins, wasn't she though?
I'm telling you, somebody, and inflation is going up, prices are high, and she's still okay. Somebody, I'm telling you, somebody told her.
But then, I mean, I'm still I'm still got a side eye on these facilities though. Like really, I don't. And so how do you what what's the remedy behind it? I got questions. You see, I got questions.
What needs to happen is when they verify, there needs to be some kind of, but I guess it's probably privacy, but because your name is public record, your license number is
It's public record,
but not your likeness. But I think that there needs to be a way where an employer can see your picture, because everybody that has submitted a nursing license, you have to send like a passport picture to along with your application to the state, so they have it. So it's not like they can't get it. And I think that they need to allow employers access to that file so they can see, does this driver's license or whatever form of ID using, does it match this picture? Now, granted, I'm sure I don't look like I did 30 years ago.
Yeah, credit card said they need an updated picture every year.
You don't have to update, but it could be a stopgap. It could be at least one little, you know.
Especially if there are glaring differences between the folks. Like, ma'am, she's of a different race. What happened? I mean, I know there's skin diseases and skin disorders and all of those kind of things that could potentially, but really, is this what we doing? I don't know. Renee said, when you provide the license and social security number at a job, must send it to the state to confirm before they can start. Right. I mean, I know you have to do we did exclusion checks, we did all of those things. Um, but that's all they do. It's a cursory exclusion check. Has anything been attached to this particular license? If no, then they go. Because you even have issues, and I know we had few situations where have popped off once they've been employed. So they were clean, everything was clean, and some stuff popped off after the fact. And then it's like, oh, so you're not gonna say nothing about your current suspension that you got because of some stuff you did since you've been employed. Like, and so you have to do a good compliance plan. We'll be checking these on a monthly basis. You have to run monthly checks on these things to verify a good compliance plan.
You see, that's why she was focused on long-term care
because they don't even have the resources to look. We just glad you here. Thank you.
Because like when you work at large institutions like hospitals, even like where I work, they have a whole third-party company that does all that.
Mm-hmm. Mm-hmm. And then if your nursing home is affiliated with a large organization, it's part of that fold. But if you are independent nursing home or you're with a different group, they may not even, clearly they don't do those types of checks. That's a mess. That's sad. We are all at risk. Lord, I'm gonna need to play the organ music. We need to have to go into prayer. And go into prayer. All right, all right. Well, this has been good. This has been good. I have learned some things today that yeah, we definitely gonna come back on and talk. I got to do some digging, look for some folks and see what's happening. I love my Saturdays. I love my Saturday morning. I get an education all the time. Like I said, y'all think this for you. Sometimes it be for me too. It be for me too. All right. Well, Mr. Jesse, you have any last words? Anything you want to add and or say to the people as we're about to close?
I think this was great. I mean, we just see how due diligence is just key.
Mm-hmm.
When you're out here in these medical records, just do the right thing.
Do the right thing. It's not that hard. For real, for real. It's not that hard. So yeah, well, thank you all for joining us with the Saturday morning tea. Was the tea spilled today? I'll say the tea was spilled. I got some tea.
Before we go,
Yes, sir.
One of my former co-workers, Sophia, has joined.
Well, welcome. Hey, welcome. Glad to see you. Feel free to definitely come back. That's fun. Don't you love that? If this information was valuable for you, help us share this message with others by sharing the video. Yes, Renita said the tea was spilled. By sharing this video with others and subscribing to the channel, Professional Reimbursement Network. Y'all know I got a goal, trying to get to 10,000 with a stretch goal of 1 million. No, I'm kidding. That's a big stretch, but whatever. I'm trusting and believing. Let me play my organ music. Trusting and believing. And as you leave, don't forget, if you haven't already, to hit the thumbs up or like button for the engagement that allows us to be seen in other places by other folks who also may want to know the information and the tea that we spill. You can also check out the Coding Nurse channel on YouTube and subscribe there as well. Last but certainly not least, to the Clubhouse folks, we are in houses now, so join the house so you can get information about what's happening with the Certified Marketable Medical Coders group. Again, this has been a great session today. Thank you all for joining. Hopefully you got some wonderful weather. It's been hot. That's another thing. It's been hot here. unseasonably hot. Like, where did this come from? Lord, give us strength.
Power briefly went out. It was just from the heat.
Yeah, it's from the heat. And that's, you're going to see those rolling outages too. That's going to be scary too. That's a whole other conversation we could talk about. Ooh,
Well,
go ahead.
It's not a church announcement, but I'm getting ready to go. Well, actually, from 11 to 2, I have a 2-hour sequel tutoring session. And I'm telling you, I've been hyped up all week because we are getting ready to do some work. Because I had already talked to him because I'm like, I know that there's a way to get, because a lot of independent practitioners use Microsoft Excel to keep track of all their codes and all this information. So when I was talking to my tutor last week, I had mentioned to him about this ad that I sent. So I showed him. So he told me, he was like, well, actually a lot of people don't know it, but everything you can do in Microsoft Excel, you can do with SQL. It's a little easier.
Really?
So I said, so then I just went down a rabbit hole and started watching videos on how to import Excel files into SQL. So that's what we're going to do today. And when I get it down pat, you know how much data analysis you'll be able to do?
Oh my God. Love it.
You have there's a lot of people, there's a lot of practitioners who, and healthcare is surrounded by tons and tons of data.
Yes, all of it is.
Right. And they don't know how to analyze it. Like they probably don't know what's the most frequent conditions in their practice, how many people they've seen, how long it's been since between appointments for their client, their patient. And that's all just a couple, lines of code.
This gonna be fun. Look at you, our IT guru. I love it.
I'm ready.
I love it.
I'm trying to get to the dinero.
Oh, that international bag. You better speak it into existence. You better speak it. I love it. I love it. All right, y'all. Give y'all a little something to think about for the week. This has been a great session. Thank you all for joining. And remember, be safe, be kind, and don't wish for it. Work for it. Until next time, take care. Thank you for joining. Bye.